Welcome to the module Working with Adult Medicine. This is the 8th of 10 modules in the course. By the end of this module, you will be able to discuss the importance of working with adult medicine during the healthcare transition, list ways to engage adult-oriented providers in the transition, utilize strategies to build your referral base of providers for the care transfer, and identify appropriate transition service reimbursement codes for providers. This module focuses on approaching the practices, hospitals, and tertiary care that will serve patients after they transition out of pediatric care. A 38-year-old woman with cystic fibrosis schedules a medical appointment to talk about fertility concerns, carpal tunnel symptoms, and recent weight gain. Is her pediatrician the best fit for this appointment? Instead of waiting for your patients to age or present with symptoms of heart disease, the patient should transfer to adult care in early adulthood. Referral options for the primary care transfer include family physicians, internists, and med-peds. Note that med-peds are the most rare of the three. Unfortunately, many in adult medicine see this as a pediatric problem. Others understand perfectly why they should accept a patient in their 40s who happens to have a childhood onset condition, but are reluctant to accept a patient in their 20s or 30s. Thus, pediatric providers' transition activities are not limited to the patient's preparations, but include preparing colleagues in adult medicine. The next slide presents a video of a panel interview.
Just plan earlier on. I came back from college after not having any kind of interaction with my pediatrician for a couple of years, and then asked him, so who do I go see? And he had no idea. And I think it's probably a lot harder to find an internist or someone who's willing to deal with someone with special health care needs than it is for a child who doesn't have special health care needs. So plan earlier on.
Efforts are underway to train adult-oriented providers on the needs of patients with childhood onset conditions and on their role in addressing the medical needs of this growing population. For a successful transition, pediatric providers must prepare patients before the care transfer, and adult-oriented providers must engage patients after the transfer. In the current state, transition outcomes commonly fall into one of the following categories: everything stays the same, mixed transition, full transition, and dropping out. Key to a successful full transition is careful planning, the development of healthcare skills by the young adult, and good communication between all of the pediatric and adult healthcare providers. The fields in adult medicine are highly focused on what they term the gray tsunami, the rapidly growing population of elderly patients. Two factors account for this tsunami: the baby boom generation and the advances in medicine that have added years to life. Many practitioners in these fields do not realize that young adults with childhood onset conditions are a similar force in medicine. This tsunami is caused by two factors: improvements to screen and diagnose early childhood conditions, and the advances in medicine that have added decades to life for complex conditions. The AAP, AAFP, and ACP co-authored the joint statement in 2011. Many professional organizations have released subsequent publications in support. In recent years, the number of trainings available through the medical boards and state organizations has also increased. For example, the ACP released a number of tools to help adult care clinicians integrate transition-age patients into their practices. These efforts focus on specific conditions such as intellectual and developmental disabilities, congenital heart disease, diabetes, sickle cell disease, and juvenile arthritis. The National Center's 6 core elements use existing evidence to create practice-based recommendations for adult-oriented providers and condition-specific tools. The next section will describe common barriers that providers face while moving between pediatric and adult medicine. Common phrases can create barriers between the fields. For example, Outside of the pediatric world, adult medicine is just medicine. The phrases transitions in care or just transition typically relate to inpatient care, transition from hospital or nursing facility to the home. Using this phrase to describe transition from pediatric to adult medicine is less known among internists. Finally, the phrase youth with special healthcare needs and its correlated acronyms simply do not exist in adult medicine. Internists and adult-oriented specialists find the phrase intimidating. The shortage of referral sources, both for primary and specialty care, for patients with childhood onset conditions is the main barrier to care transfer. Patient and family reluctance to transfer only compounds this barrier. Many adult-oriented providers have never been exposed to childhood onset conditions, even during their training. Healthy young adults are the least likely demographic group to seek primary care. Internists may be unaccustomed to the age group or skeptical of their ability to keep appointments, follow care plans independently, etc. Many providers cite coding and reimbursement for transition care as a barrier to implementation. This affects pediatric and adult-oriented providers in many settings. New policies for reimbursement of care coordination activities can address this barrier. The National Center for Healthcare Transition also offers resources for transition care coding and a reimbursement tip sheet. It includes information for different payment models, such as enhanced fee-for-service, pay-for-performance, capitation, bundled payments, shared savings, and administrative and infrastructure payments. The next slide presents a video of an interview.
The thing that they do that is different than other people that is great.
I don't have much experience with other doctors. I don't know if other doctors are like this or not, but I've always, especially with my current doctor and also Dr. Rosenberg, always treated me as if I was never looked down on. Because I was younger. I was always asked the most serious or direct questions about my health were asked directly to me, and they valued what I had to say about it. They weren't types of doctors that would just send me to lab tests and get some blood and then they'd decide what was wrong with me. I was very involved in the process of my health care, and I was always involved in the decision making based upon what my symptoms were, how my treatments were going to proceed. They always kind of included me in that decision making process. So that I think is very helpful and continues to be nice to know that they're actually listening to what I'm saying and at times are letting me control some of the treatments and letting me control how my healthcare is proceeding. I'm still seeing a pediatrician, but I see him about 3 or 4 times a year, but I don't envision myself really seeing other doctors because I really haven't had to deal with that. I guess my doctor now looks at children under 6 months of age, newborns and intensive care is what he mainly deals with. And so I'm his oldest patient, and by far, and I think he might have 1 or 2 that are near me, but I think his only adult patient. So that probably presents some challenges for him. If it does, it present any major challenges, I haven't seen it. He he's an excellent physician, and seems to really know what he's doing and everything. Anytime I've ever had trouble, he's always been able to prescribe and recommend things that work nearly every time. So I'm completely happy with where I'm at. As long as he feels comfortable seeing me, I feel extremely comfortable continuing being seen by him.
Okay. Well, your mother would really like to see you someplace else. So that's good, and you don't really have a vision for something different because you're happy where you're at, right? And
I mean, I'm sure things will change in the future, and that maybe I'll have to, especially if I move to another city, which is very probable. I'd have to find another physician that specializes in either CF or pulmonology or something of that nature. But right now I'm fine, and as long as I'm in Indianapolis, I don't see any reason to change at this time. I think that's a part of. I think the reason for that is that I am so independent. I don't see my doctor a whole lot. Like I said, 3 or 4 times a year, or when I have specific trouble, infections or whatnot. So I'd like to have as little contact with physicians as possible, as anybody would, and so I'm not going to actively or proactively go seek out other physicians to get involved with. It just doesn't really matter that much to me.
As long as you're healthy, right?
The next section outlines steps to address these barriers. Present this population as an opportunity for your colleagues to grow their practice. Internists need not become an expert in childhood disease to provide care. A young adult with cystic fibrosis would continue to see a specialist in lung and pancreatic diseases. Using the medical neighborhood concept will illustrate the many supports available to individual providers willing to accept transitioning youth as new patients. Internists provide a primary care medical home to adults. They have all the skills they need to care for this patient population. If they have senior citizens in their patient panel, they already see patients who rely on a personal attendant, see patients with an adult child as a healthcare decision maker or power of attorney, assess motor or cognitive function changes, and accommodate patients post-surgery. Direct your colleagues to resources on transitioning youth or on particular conditions. Consider offering yourself as a consultation source for individual patients or colleagues. The next slide presents a case vignette.
Initially, when we were talking about switching, I thought it was going to be an easy step. I thought that he would just switch and transition to our providers. It was a large practice, and the pediatrician felt very uncomfortable about doing that. She felt that if we went to a practice of 12 doctors, that Jeff would have 12 times he'd have to explain his history, that he would have to explain it again when he went back and saw the provider that he hadn't seen in the last 3 years, and that he could end up with just about anyone, and their philosophy may not mirror what she felt needed to be mirrored when he needed care and he was older. So she felt that he really needed to go to a small practice of 1, possibly 2 practitioners who would become very familiar and intimate with Jeffrey.
I was very involved in terms of making the decision to switch from Dr. Pimpani to Dr. Gardner. My parents would never make that decision for me without consulting me. Because in a sense, I mean, I need to be happy seeing the doctor I'm seeing. I need to be able to trust this doctor.
In the beginning, there's issues of getting to know what his medical problems are and what they might be. And now, as he's transitioning out into the community from college, there's going to be issues of personal care, interaction with other people, issues of sexuality.
At the age of 18, Dr. Shapiro offered me, shall I say, another alternative. Instead of seeing him, I could see somebody that deals with older patients. I chose to stay with Dr. Shapiro because he has seen me basically since I was born. I mean, he knows me better than any other doctor. And I personally didn't and continue not to feel comfortable going to somebody who, in a sense, has to learn my case report all over again. I mean, I've always felt very comfortable with Dr. Shapiro. I know he makes very competent decisions regarding my care, and I will continue going to him for the foreseeable future.
Generally, with a lot of these childhood diseases, the very complicated ones, that many adult physicians have never seen the disease. So you lose a degree of expertise when they just appear suddenly with a disorder they're not familiar with. So that's the reason that many are continued here.
Jeff and his family have combined pediatric specialty care and adult-oriented primary care to best meet Jeff's medical needs.
I think the most positive thing about switching from a pediatric to an internist is more or less it's a sign that you're growing up. It's a sign that you're starting to take charge of your life.
So I think the most important thing that I do when I'm transitioning any adolescent from an adolescent or a pediatric practice to an adult practice is I tell them right off the bat that what they tell me within the privacy of the room is between us. So they usually breathe a big sigh of relief, and then whatever issues they have, they can talk about openly because they know that I'm not going to blab it to their parents.
The next section identifies strategies for building your referral network and maintaining referral sources. Use your professional network to build a referral network of adult-oriented providers. Encourage your practice staff to reach out to their counterparts. Contact the Florida Board of Medicine to locate adult-oriented providers in your area. The Florida chapter of the American Academy of Family Physicians has a physician locator tool on their website. Check the Florida chapter of the American College of Physicians website for information to locate internists. Patient advocacy groups are rich resources to identify providers comfortable with childhood onset conditions. While your staff members may be quite familiar with social service agencies that work with children with disabilities, you may not be as familiar with those that serve adults. The ARC of Florida, the Agency for People with Disabilities, and the Centers for Independent Living all work with adults. They may be able to connect your patients with condition-specific support groups or with adult-oriented providers who have a good reputation among their adult clients. List 3 to 4 places you will look to build your referral network of adult-oriented providers. This slide will automatically advance after 1 minute, giving you time to write down your responses. When referring individual patients, provide important facts such as the patient's ability to make decisions and manage their condition. Let the new provider know the status of specialty referrals and transfer. Encourage your colleague to use the patient or parent or caregiver as an educator on their childhood onset condition. Offer a bridge medical visit where both the pediatric and adult-oriented provider meet with the patient. This is a popular strategy to facilitate transition, but may be difficult to arrange. Other popular strategies include connecting each practice's care coordinators or front desk staff. Let the new provider know your ability for phone consultation. The National Center for Healthcare Transition offers many practice-based tools that support adult medicine. These include example visit flow sheets, welcome and orientation for new young adult patients, sample care plans, condition fact sheets, self-care assessments, and practice self-assessments. The American College of Physicians released a new program on transition for internists. It focuses on receiving new patients into the practice and coordinating care with pediatric providers during the handoff. It includes a series of toolkits with condition-specific resources for subspecialties in the field of internal medicine. The next slide presents a video of an interview.
My pediatrician, Dr. Pinnapati, treated me until I was around, say, 16, 18, around in there. And then she, at that point, referred me to a list of internists that she thought would be good for me to see. It was easier for me to leave Dr. Pinnapati. Believe me, she gave excellent care, and I would recommend her highly, but it was easier leaving her because the care that I receive from the pediatrician and the internist isn't directly related to my disability. It's more or less about regular illnesses like the flu, colds, whatever. So I think in that sense, it felt more natural going to a grown-up doctor, if you will. I don't think Dr. Gardner, the internist, necessarily can address my healthcare needs better than Dr. Pinapati could. They're both very competent. But Dr. Pinapati is a pediatrician, that's what she specializes in, and Dr. Gardner is an internist, and that's what he specializes in. So, being that I was of that age, I just felt it was more appropriate. And besides, in regards to some of the more personal things like the annual physical, I thought it was more appropriate to start seeing a male doctor at that point.
Before closing this module, let's review resources discussed in this presentation and key points. Transitioning youth are an emerging population in adult medicine. Supporting adult-oriented providers is crucial to continuous, accessible, and appropriate patient care. Use the links from this course's toolkit to access the resources from this module. Engaging adult medicine is one side of the care transfer. The next presentation examines the patient side of this activity. You can pause the course for a short break or continue on to the next module.